teaching us. We came up with like what you are doing. We thought we will do that too. So I developed interest in teaching, and thanks to you a lot. I will never forget you in my critical care life. You have given me a new life. And as sir said, we manage cases in a remote place, but the credit should go to our whole team. I alone can't do anything, everything and everything. 365 days, 24 hours is not possible. We have got a team of 4 people who work round the clock. So with that, I'll start. We have already finished part one where we spoke about oxygenation and ventilation. Now I'll next in this session I'll talk about interpretation of acid base status. Then later on there will be few examples where we will solve the whole ABG. Okay, I'll give a clinical scenario and solve the whole ABG. Dr. Raghu, I think you can
Yes.
see the screen.
Yes, sir. Yes,
Yeah,
sir.
yeah. Okay. So, continuing our previous session of interpretation of ABG, now we'll move to the interpretation of acid-base status. We have done already oxygenation and ventilation. So, interpretation of acid-base status is very important in the sense for oxygenation you have got 4 steps, like the ABG will give the PA2 value where you say it is hypoxemia or hyperoxemia or normoxemia. Then expected oxygen PaO2 you should calculate, then the AA gradient, and then the PF ratio. And ventilation is still simple, just you see the PCO2 value and you say whether it is an alkalosis or an acidosis. But here acid base status is little more complicated in the sense if you start doing regularly, it becomes an habit. I still remember when I was with the Dr. Raghu, simplest thing I couldn't understand. But in the course of time, when I kept on doing it repeatedly, then I started understanding what exactly is how the ABG helps in managing the patient. So acid-base status, there have been 3 main methods of evaluating it. One is the strong ion difference method, that is a Fenkel-Stewart method, which uses few very complicated calculations. But it is a very robust approach, actually, if you see, and it is very simple, actually. But it needs few calculation in between. Then is the Boston method, which is also called as a traditional method. Okay, it is a traditional method which most of us do. And most of them practice all over the world, and it is also called as a bicarbonate centered approach. Next is the Copenhagen method, which is a base excess. So most of the ABGs will show base excess is -4 or -8 or +4. So what exactly they mean is, so what base excess is, it is the amount of base or an acid to be added to make the pH come back to 7.4, but it is an in vitro method. It's not an in vivo. It is the base excess or base deficit is the amount of acid or base to be added to the solution to bring back the pH back to 7.4 at 37 degrees centigrade. With there the PaCO2 is 40. So it is calculated at the level 40, and the hemoglobin to be around 5 gram %. So that is how you have to. That is how the Copenhagen method is done. So sometimes they say that the base excess is -4. That means that when it is a -4, that means it is an acidosis. Base excess, actually it is a base deficit, but they say that if you say base deficit, then it will be a positive number. But if it is a base excess and if they say -4, then it is a negative number and it means acidosis. And base excess +4, +5, +6 means it is alkalosis. Normal base excess is -2 to +2. Okay. So that is and here today we will be discussing exclusively the Boston method, which is a bicarbonate centered approach. So what does actually means? There are few assumptions if you have to go through by the Boston approach. They say that the components of bicarbonate and carbon dioxide are in equilibrium with the non-bicarbonate buffers. So what are the non-bicarbonate buffers? Albumin, which is a weak acid, phosphate, and hemoglobin. So hemoglobin is one of the very, very important buffers. Through the globulin, through the hemoglobin, it plays a very important role in buffering the system. Okay. Also, bicarbonate buffer is a in Boston approach. What they do is they use the bicarbonate as a main buffering system of the extracellular fluid because it is quite abundant. Unfortunately, the non-bicarbonate buffers are not so much abundant, but they still play a role in the acid-base status. In the last class, I told for calculation purpose, the pH is taken as 7.4, the PCO2 40, the bicarb is 24, and the anion gap is 12. So this is exclusive for calculation purpose because whenever there is a range, we get confused if they give a pH as 7.44, then they give a equation, then you don't know what to say because the normal range is 7.35 to 7.45. But for calculation purpose, you always take it as 7.4. So you keep these values fixed in your mind. So coming to the steps in interpretation of the acid-base status. So first you look at the pH, then you will see the PCO2 and the bicarb, and look which is matching the pH. So that will be the primary disorder. Okay, if the pH is 7.3 and the PCO2 is 60 and bicarb is around 26. So the primary disorder here is the respiratory one. If, for example, if the PCO2 is 18, okay, and bicarb is around 10 and the pH is 7.3, then it is more in favor of a metabolic acidosis. So what is important is once you know the pH, next thing is you should look for the primary disorder. Once you look at the primary disorder, next you have to look at the compensation. If the primary disorder is a metabolic one, then you have to look at the respiratory compensation. If at all there is a primary disorder is a respiratory, then you have to look at the metabolic compensation. So if there is a metabolic acidosis, so the compensation will be respiratory alkalosis. And if it is a respiratory acidosis, it will be a metabolic alkalosis. So it will go in opposite directions. Okay, so that is how because the body is a neutral, electrically neutral. Okay, so that is how the body tries to compensate for the disorders. Once you calculate the compensation, then you do if it is a metabolic acidosis, what you do is the anion gap. Okay, so anion gap is sodium. How do you calculate? It is sodium minus chloride plus bicarbonate. Basically, it is the difference between the unmeasured anion and the unmeasured cation. But it is calculated through this formula, that is sodium minus chloride plus bicarbonate. Some people take sodium plus potassium minus chloride plus bicarbonate, but don't get confused. You have to stick to sodium minus chloride plus bicarbonate. Okay, in the next slide I'll show what a Gamble gram is. There you can understand why I am trying to why we have to do the anion gap. Then because albumin is one of the weak acid, it plays a very important role in the acid base status, and most of our critically ill patients are hypoalbuminic. So whenever there is when you see a metabolic acidosis, then calculate the anion gap. If you go with that, then there may be a wrong interpretation of the disease. So you should always try to, if at all albumin is given, you should always try to calculate you should give the albumin correction, which I'll show in the later slide. Then we either do a delta ratio or the delta gap to look for the mixed disorders. So here, how do you do a calculation for metabolic disorders? If it is a metabolic acidosis, to know the expected PCO2, we do something called as the Winter's formula. That is 1.5 times the bicarbonate plus 8 plus or minus 2. For example, if the PCO2 given is 30 and bicarb is around 15, so what will be the and if it is the primary disorder is a metabolic disorder, so what is the compensation if you have to calculate by Winter's formula? So 15 into 1.5 plus 8. So 15 into 1.5 is 22.5 plus 8 is equal to 30.5. And the given PCO2 is 30. So it is a compensated metabolic acidosis. Coming to metabolic alkalosis. So what is the expected respiratory compensation for metabolic alkalosis? The formula is 0.7 times bicarbonate plus 21 plus or minus 2, or some people take it as plus or minus 5(2). Okay, so what we do is, if at all bicarbonate is given as 30, okay, and alkalosis and the PCO2 is around 40. This is PCO2 and this is bicarb. So how do we calculate? 30 into 0.7 plus 21. So 30 into 0.7 will be 21 plus 21. So is equal to 42. So the given PCO2 is 40. So it is an compensated metabolic alkalosis. So this is the formula to know whether it is a metabolic acidosis or the metabolic, whether the compensation is adequate. In alkalosis, this is the formula. And for metabolic acidosis, to look at the compensation, this is the formula, which is called as the Winter's formula. We'll see in the few examples later. Next, if at all the primary disorder is a respiratory disorder, then you have to calculate whether there is adequate metabolic compensation. So what you have to look is for the expected bicarbonate. So the chart is like this. For every 10 millimeter change in PCO2, actually this should have come as PCO2, for every 10 change in PCO2, if it is respiratory acidosis, what I mean to say is, if the PCO2 moves from 40 to 50, for example, there is a 10 millimeter change. So what can you expect? You should expect an metabolic alkalosis. So in acute, it will change by 1. That is, the bicarb will raise from 24 to 25. And if it is a chronic, some people take it as 3 or some as 4. The compensation will be 24 plus 3, which will be 27. Okay. For if the patient has got respiratory acidosis, primary respiratory acidosis, if it is an acute respiratory acidosis, the change in bicarb, that is, the increase in bicarb is from 24 by 1, from 24 to 25 it becomes. And if it is a chronic, then it will be 3 by 3. Similarly, if it is a respiratory alkalosis, so what do you expect? The compensation in respiratory alkalosis is a metabolic acidosis. So for if the PCO2 has changed from 40 to 30, so this is respiratory alkalosis. There is a 10 change. For every 10 change of respiratory alkalosis in acute, the bicarb will reduce by 2. That is, if the bicarb, normal bicarb is 4, the expected bicarb will be 22. And similarly, in the chronic, for every 10 change, there will be a 5 decrease in bicarb. So if at all it is a chronic respiratory alkalosis, okay, so what bicarbonate you can expect is 24 minus 5, it is 19. Got it? For a respiratory acidosis, in acute respiratory acidosis, there is an increase of bicarb by 1, and in chronic it will be increased by 3 or 4. And in alkalosis, if there is a respiratory alkalosis, you expect a metabolic acidosis. So the bicarb reduces by 2 in acute and chronic, 5 in chronic. Similarly, if it is 40 to 20, then the change is 20 millimeters of mercury. If the normal PCO2 is 40, if the given PCO2 is 20, then there is a 20 change. So again, similarly, you calculate the compensation in metabolic compensation accordingly. So this is what we have to understand to know what is the anion gap. This is called as a Gamble graph, which was created by the pioneer Gamble. I think he's an Italian or a French guy, French scientist. So what he said is, in a normal plasma, the main the main cation is the sodium, okay, and the main anions are bicarbonate and chloride. But there are so many unmeasured cations and unmeasured anions, okay. So whenever you normally, if you calculate anion gap, it is 8 to 16, okay. So the sodium minus chloride plus bicarbonate will give you the anion gap, and in a normal plasma, so this is the anion gap. This part is the anion gap. So this is a measured of measurement of unmeasured anion. So that is the gap. So you can see the chloride is normal here. Probably it will be around 100. The bicarbonate will be around 24. The sodium will be around 135. So 135 minus 124 will be around 11. So as we know, it is 8 to 16, and for calculation purpose, it will be 12. So 135 minus 24 plus 100 is 124. So it is 11. So what you have to notice, this is a normal anion gap. But what happens in non-anion gap or normal anion gap metabolic acidosis is the bicarb has reduced here. You compare this with this. So bicarb has reduced and the chloride has increased. The chloride has increased. Okay, but the anion gap remains the same. There is no change. So the anion gap will be around 12. So I'll tell you what are the conditions where you'll get a normal anion gap. So one of the commonest what we see is in the hospital, after the resuscitation of normal saline, the chloride increases and it causes a hyperchloremic metabolic acidosis. So when there is a normal anion gap, the cause may be either a renal or an extra-renal cause, okay, which I'll explain to you in the future slide. And what is high anion gap metabolic acidosis? Here what happens, the chloride doesn't increase, the same chloride level remain, but the bicarbonate has decreased. That is because the amount of acids, unknown acids, hydrogen ion has increased, and that causes an wide anion gap. So that is called as a high anion gap. Okay. So this is because of increased hydrogen ions in the blood, which the hydrogen combines with bicarbonate and the bicarbonate levels come down. So in high anion gap metabolic acidosis, the amount of unmeasured anions are very high. Okay, and that is the whole challenge of an intensivist, to know what is that unmeasured anion which is causing the metabolic acidosis. So in the following slide, we'll come to know the causes. And as I said, once you calculate the anion gap, next you have to, if the albumin value is given, invariably we do an LFT and you get an albumin value, then you have to correct the anion gap by using the albumin correction. Normal albumin is around 3.5 to 5.5 grams per deciliter. Okay, if they take liters, it will be 35 to 55. Okay, that you should keep in mind. So when it is given in deciliters, it is 3.5 to 5.5. So how do you do an albumin correction? The albumin correction is, we take for calculation purpose, the albumin as 4, then the given albumin, if at all in this in a particular example, if the given albumin is 2. So this is 4 minus 2, and for every gram, you have to multiply it by 2.5. So 4 minus 2 is 2 into 2.5 is equal to 5. So you should add this value to the anion gap you have got. Then you will come to know the real anion gap. That is, if the albumin was corrected, if the albumin was normal, the anion gap would have been still higher. So always don't miss to do the albumin correction. Now I am giving you an example. So in this example, the sodium is 135, chloride is 110, and bicarbonate is 15, and albumin is 2 grams. So when you calculate the anion gap, it is 135 minus 110 plus 15, isn't it? So it will be 10. So what is if it is the normal anion gap we take is 12. So if it is less than 12, it is a normal anion gap. But because the albumin is 2, when you do an albumin correction, so you have to add 5 of this. So for every 1 gram, you have to multiply by 2.5. So it is 2 grams. You have to multiply by 2.5. That will be 5. So now when you add this 5 to this anion gap, then see, which we thought nagma is actually not nagma, it is hagma. So you should always do an albumin correction when you do an acid-base disorder. Basically, that's the reason I told most of your critical ill patient are hypoalbuminic. And next, what you do is either you do a delta ratio or a delta gap. Delta ratio is the delta anion gap minus delta bicarb. So we know that, so we'll calculate an anion gap. For example, if the anion gap is 16 and the normal anion gap is 12, okay, then we divide it by, if the bicarb is given bicarb is around 10, so what you do is 24 is normal and the 10 if they have given it, so you do the delta ratio, so that will come to 4 divided by 14. Okay, and this will come to some value, probably about less than 0.4. Okay, and based on that, if the your delta ratio comes to 0 to 0.4, then there is only normal anion gap metabolic acidosis. If the delta ratio comes between 0.4 to 0.8, it is mixed normal and raised anion gap. If the delta ratio is 1 to 2, it is only hagma. And if the delta ratio is greater than 2, then there is an metabolic alkalosis associated with metabolic acidosis. So this will help you to find out the hidden disorders, or yeah, exactly, hidden disorder or triple disorder, whatever it is. So many times we will just calculate anion gap and say that is a high anion gap metabolic acidosis, but the patient may be vomiting and losing lot of blood. So many clinical scenarios are given. So that time there will be an associated metabolic alkalosis, and you have to do a delta ratio or a delta gap. So next, coming to what is delta gap. Why we do either of them is sometimes we'll get a negative value. For example, in a normal anion gap, so if the anion gap is less than 12, so if you get an, for example, you get 12 as an calculated anion gap. So if you have to calculate a ratio, but there will be acidosis, what will happen is, and if the bicarbonate is around 14, here you get a negative value, it is not, you feel very confused to divide it. So if you do a delta ratio, as I said, here instead of doing a ratio, you just subtract it. So what you will do is, delta anion gap is 10 minus 12 minus 24 minus 14. So it is minus 2 minus 10. So minus 2 and minus 10 will be minus 12. Okay, minus, so what is minus 12? If the delta gap is less than minus 6, okay, it is a mixed high anion and an normal anion gap. If the delta gap is between minus 6 to plus 4, then it is high anion gap. And if the delta gap is greater than plus 6, then it is a high anion gap metabolic acidosis and a metabolic alkalosis. So this is how you should try to find out the hidden disorder, either by doing a delta ratio or a delta gap. So I am clear on this. This is, you divide delta anion gap by delta by carb, but here you subtract delta anion gap by delta bicarb. Basically, what we are trying to see is whether the change in bicarb is proportional to the change in anion gap. If they are equal, that means that there is only a high anion gap. If there is some discrepancy between that, then we have to see whether there is only high anion gap or there is a metabolic acidosis or a normal anion gap. So what are the causes for high anion gap metabolic acidosis? There is a mnemonic called as mud piles cat. So methanol, uremia, diabetic ketoacidosis. Basically, it can be diabetic, it can be starvation, or it can be alcoholic ketoacidosis. So any ketoacidosis can cause high anion gap metabolic acidosis. So it can be either because of diabetes, it can be because of starvation, and it can be because of alcoholic. Then paraldehyde or paracetamol can cause high anion gap. Iron and isoniazid, lactic acidosis, ethanol, ethylene glycol, methanol poisoning, all alcohol poisoning cause high anion gap, and salicylates and aspirin. Similarly, carbon monoxide poisoning or aminoglycoside toxicity or theophylline, they all cause high anion gap metabolic acidosis. Now, one of the other thing is when you get a normal anion gap, you should when you get a normal anion gap metabolic acidosis, next you should know what is the cause for normal anion gap metabolic acidosis. Is it because of a renal cause or it is because of extra renal cause? So I showed the Gamble gram. There what happens is the bicarb is reduced, either the chloride is increased, isn't it? So now you have to find what is the cause for this normal anion gap, and what we do is a urinary anion gap. You should ask the lab to get a urinary electrolytes. So urinary anion gap is calculated by urine sodium plus urinary potassium minus urinary chloride. Okay, so what you have to see is the product or the result of this is whether it is positive or negative. If the urinary anion gap is positive, okay, then the cause is renal. Okay, and if the urinary anion gap is negative, then the cause is extrarenal. Okay, normally the urinary gap is positive and it is a measure of urinary excretion of hydrogen ions in the form of ammonium. This is what we have to try to understand. So the urinary pH and everything depends on the excretion of ammonium ions. So if the urinary anion gap is positive, then the cause for NAGMA is renal, that is renal tubular acidosis. Okay, and if the urinary anion gap is negative, then the cause is extrarenal, which can be iatrogenic or a GI loss. Okay. So in cases of loss of bicarbonate by GI system, kidney compensates by increasing excretion of ammonium ions in the form of ammonium chloride. This leads to a decrease in urinary anion gap. Okay. If the loss of bases is of renal origin, then urinary anion gap is unchanged or it is positive. So the flow is simple. You do a urinary anion gap. If it is positive, then the cause is renal, and most probably it is an RTA. It can be type 1, type 2, or type 4. For that, again, what we do is, if you get as a positive urinary anion gap, then the cause is RTA, renal tubular acidosis. Here, what you do is, next you ask for the urinary pH. Okay, if the urinary pH is more than 6, then if the urinary pH is more than 6, then it is RTA type 1. Okay, if the urinary pH you get is around less than 5.5, or if it is more acidic, then it is an RTA type 2. Okay, but here the serum potassium is either normal or there will be hypokalemia. But if the pH, urinary pH is less than 5.5 and serum potassium is greater than 5, then the issue is it is an RTA type 4. So RTA type 1 is proximal RTA, Then RTA type 2 is, type 1 is distal RTA, type 2 is proximal RTA, and type 4 is both proximal and distal RTA. So whenever you get a positive anion gap, you should always ask for urinary pH, and if whether the urinary pH is more than 6 or less than 5.5. If it is more than 6, straight away the answer is RTA. The cause is RTA type 1. If the pH is less than 5.5, then you should see what is the serum potassium. If the potassium is normal or decreased, then it is RTA type 2. And if the potassium is increased, then it is RTA type 4. Okay, this will complete the evaluation of urinary anion gap. Evaluation of normal anion gap metabolic acidosis. You should not stop by just telling that there is a normal anion gap metabolic acidosis. You should try to find out what is the cause for normal anion gap metabolic acidosis, and you will get only when you do an urinary anion gap and urinary pH. So what are the causes of normal anion gap metabolic acidosis? The mnemonic is used carb. There are many mnemonics for that. So U stands for ureteroenterostomy, small bowel fistula. This is the iatrogenic cause. Extra chloride can cause nagma. Then diarrhea. When there is severe diarrhea, there is a lot of loss of hydrogen bicarbonate. Okay, so that causes nagma. If the patient is taking carbonic anhydrase inhibitor like acetazolamide, then long-term use can cause nagma, or Addison's disease, where the raised potassium will cause loss of acids in the urine and causing a negative urinary anion gap. Then renal tubular acidosis and pancreatic fistula. These are the causes for nagma. So now we will solve one by one examples so that you can understand. Now we will be clubbing what we saw in the part 1 of my lecture, and part 2 will combine it. So I have put few fonts in red because whenever a clinical scenario is given, every point is important. Here they say it's a 60-year-old man was admitted with gluteal abscess. So your thinking should go towards sepsis. He is a known diabetic with on oral hypoglycemics. So many of the oral hypoglycemics in acute kidney injury or chronic kidney injury causes acidosis. Then decreased oral intake. This you should keep in mind, because they'll give a scenario decreased oral intake and then you suddenly feed the patient, then it is refeeding syndrome. So this is how you, in exams you have to make it. Then his blood pressure is low and was resuscitated with the IV fluids and was normalized. Then you should think of nagma because of hyperchloremia. He was started on 6 liters of oxygen via face mask. ABG is done in the what shows the following. What is the cause for breathing difficulty and what is the acid-base disturbance? So these are the values. The pH is 7.3. The PCO2 is 9. The bicarb is, PCO2 is 18. The bicarb is 9. Sodium is 138. Potassium is 4.1. Then 113 is the chloride. Lactates are high. Then the albumin is low and PaCO2 is 56. Now we will go stepwise how to solve this ABG. So first thing I told, you have to check the validity of the ABG, and we saw in the last class the validity of ABG is you do 24 into CO2 PCO2 divided by bicarbonate. We have already calculated, it has come as 48. Now the pH given is 7.3. What you have to see is whether it is matching with that pH, and yes. So this is around 48, which is nearing to 50, and the pH is 7.3. So now you know that the ABG is valid. Validity of ABG is only for your exam purpose. Nowadays, all the machines automatically calculate the validity, because when you put a blood sample in an ABG machine, it will calculate only the pH and the PCO2. Okay, the machine calculates the bicarb using the Henderson-Hasselbalch equation. So there is no chance of you having an invalid ABG. Okay. Next, once you know the validity, now you check for the oxygenation status. So what we saw is this patient PaO2 is 56. So it is hypoxemia. That is the first step, hypoxemia. The second step, expected PaO2. If it is how much is FiO2? FiO2 is 6 liters, so you can take it as approximately 40. So 4 into 4 into FiO2. What is FiO2? Expected FiO2, isn't it? So you can expect 4 into 50. So it should have been 200. Five times, sorry, 5 times the FiO2 is the calculation. Here you can take approximately 40. So that is 200. Okay, but the what PaO2 we got is 60. So it is definitely hypoxemia. And then you do the A gradient to know whether the problem is with the lung, or is it because with the because of hypoventilation or some neurological cause, or is it because of the lung pathology. So we have calculated using the formula which I had told, the A gradient formula, and the thing has come to 258. We saw different examples in the previous session. So it has come, the alveolar oxygen has come as 258. So you minus the alveolar oxygen with the arterial oxygen. So the A gradient is 202. The expected A gradient for the patient's age is, because the patient age is 70. So 70 age divided by 4 plus 4 is the formula. So what we have calculated is 17.4. So definitely the A gradient is very high, indicating that there is some lung pathology. So A gradient is increased. So there is either an additional shunt or a VQ mismatch causing hypoxemia and breathing. And the clinician has to now rule out whether it is a pneumonia, PE, or other causes. Next, coming to the ventilation status. So the value, the PaCO2 they have given is 18. So I have to just say that it is respiratory alkalosis. Only when you go next to the acid-base disorder, that time you should see whether this alkalosis is adequate, is the proper one, or whether there is an additional respiratory alkalosis. So we know that 40 is a normal PaCO2 value, and the given PaCO2 is 18. That means there is a respiratory alkalosis. Now next you evaluate the acid base status. The pH is 7.4, and you have to see whether the problem is with the bicarb or the PaCO2. So the problem is the bicarb, because the bicarbonate is 9. So the primary disorder is a metabolic disorder. So you have to calculate the compensation. So calculate 9 into 1.5 using the Winter formula plus 8. So 9 into 1.5 will be 9, how much, plus 4.5, 13.5 plus 8, it will be equal to 21.5. So the expected PaCO2 is 21.5. The given is 18. So the expected was 21.5, but the given is 18. So there is an associated respiratory alkalosis. The actual PaCO2 is less than expected. So there is an additional respiratory alkalosis. Okay, so the diagnosis in this patient is metabolic acidosis with additional respiratory alkalosis. Since the anion gap is 16, okay, there is a high anion gap. Okay, so what are the values here given? The sodium is 138 minus bicarb is 9 and chloride is 113. So this will be 134 minus 9, 10, 12. Okay, so 122. So the anion gap is around how much? Sorry, it is 122. Okay, so 138 minus 122 is 16. So the anion gap is 16. Okay, so you have to add the albumin correction for that. So the anion calculator was 16. Now you have to do albumin correction. So the given albumin is 2. So by doing that, what you got is 2.5 into normal albumin into the calculated albumin. So this will be 5. So you should add this 5 to the calculated anion gap and you'll get a 21. So the actually the anion gap is still higher. Okay, just give me a minute. I'll open the presentation so that I do not have to go back to the same this one. 1 minute, Raghu, or else every time I'm going back to the
No problem,
ABG
sir.
to see. Yeah. So next, so because there is a high anion gap, so you have to find out what are the causes for the high anion gap, which are there in this slide. Then we do a delta ratio to know whether there is an mixed disorder. So the delta anion gap, the anion gap calculated was 21, the normal is 12. So the delta anion gap is 9 and the delta bicarb is 15. So you have to divide this 9 by 15 and the value you get is 0.6. So 0.6 matches to this. So this patient is having both normal anion gap and hand gap metabolic acidosis. So putting it together, the patient has hypoxemia with respiratory alkalosis and the clinician should rule out the causes and it is HAGMA. Since lactate is only mildly elevated, the clinical suspicion is diabetic ketoacidosis. Urine ketone bodies will confirm the diagnosis and additional NAGMA is due to excessive saline resuscitation. So there is a triple disorder. There is an high anion gap or metabolic acidosis, normal anion gap, and a respiratory alkalosis. So this is how you interpret an ABG. Next, we'll go to another case. This is a 50-year-old patient who is a chronic renal failure on maintenance dialysis, has missed the last dialysis. So now you should start thinking what may be the cause for the ABG you get. And now he's complaining of breathing difficulty. He is also known case of COPD. So you can expect what the PCO2 should be on inhaler and gives history of increased cough and pink sputum. On room air, his saturation is 70%. And the ABG is, his pH is 7.1, PCO2 is 50, bicarb is 15, sodium is 140, potassium 5, sodium chloride is 105, lactates are high. They have already calculated the anion gap and PCO2 is low. So there is hypoxemia. Okay, then now we'll see how we calculate it. Again, calculating the validity. Okay, so the calculation has come as 80. Now you look at this table. For the 80, the pH should have been 7.1, and that is the this one. That is the pH which is given in the example. So it is a valid ABG. Next, oxygenation status. You calculate the AA gradient. The alveolar oxygen has come as 87. The PaO2 is 40. So the AA gradient is 47. For the patient's age, the patient is 50 years. The patient's age, the calculated AA gradient should have been 15, but it is more than that. That means that there is also an associated lung pathology, and that is the cause for hypoxemia. Okay. Now, looking at the ventilation status, the PCO2 is 50. So the patient has got respiratory acidosis. Now we should see whether it is an compensated or not compensated when you do an acid-base disorder. So the acidosis, the pH is is less than 7.4. Then there is acidosis. Now you should look at what is the primary disorder. Okay. So here there is a confusion. What has happened is both PCO2, the PCO2 is 50, which is acidotic, and the bicarb is 15. which is also acidosis. Now the problem comes. Now you will come to you should know what is the primary disorder. So what we do is we see the percentage of change of each component. Okay, how much is the expected? What is the normal bicarb? It is 24. It is from 24. It is changed to 15. And what is the normal PCO2? It is 40. It is changed from 15. So here, when you should calculate the percentage of change of each, the carbon dioxide and the bicarbonate, to know the primary disorder. So bicarbonate, if you see, the change in bicarbonate is 37.5%, whereas the change in PCO2 is 25%. Okay, this is the PCO2 we have got, isn't it? The delta PCO2 is 10. It should have been 40, but it is 15. So the delta PCO2 is 40. Okay, and the change is 25%. Whereas the change in bicarbonate is 37%. So here the dominant primary disturbance is the metabolic acidosis. So when you get such examples, you should see the percentage of change. From 24, the bicarb has come to 15. So there is almost a 37.5% change. And the PCO2 has only increased from 40 to 50. There is only 25% change. So because the higher changes in bicarb, so it is a primary metabolic disturbance. Okay, so next is you have to calculate the anion gap. So what is the anion gap? It is 8. And what is the delta bicarb? It is 9. So you divide 8 by 9, so it will come to 0.9. Okay, so what is 0.9? That means that so 0.9 is, see, again it is a confusion. 0.8 is both mixed, and if it is 1 to 2, it is only normal anion gap. So we'll see what if you do a delta ratio. Delta ratio is -8 minus of -9. Sorry, minus of 9. So -8 minus 9 will be -17. So it again probably looks like an combined this one. -17 will be where point acha. So 0.62 if it is -62 plus 6, it is only Hagma. If it is less than -6, it is both Nagma and Hagma. So -17 is definitely less than -6. So there is both Nagma and Hagma. Okay. So there is definitely no additional acid-base disorder. Okay. So finally to conclude this ABG, it is the clinical status, the clinical diagnosis, chronic renal failure. Okay, and COPD causing high anion gap metabolic acidosis and respiratory acidosis. The high anion gap is because of the renal failure, and the respiratory acidosis is because of COPD. So the cause of hypoxemia may be pulmonary edema because he has missed a dialysis, as there is a as the complaints are pink sputum. So the patient is in pulmonary edema, and that is the cause for the ventilation perfusion mismatch. Okay. Coming to case 3, this is a 73-year-old woman with rheumatoid arthritis on home oxygen. Because her pain has increased, she has increased her dose of salicylates because of flare-up. Now she complains of epigastric pain and vomiting, for the past 2 days. She went to a local hospital where the following blood results were obtained. Her saturation is 92% on 10 liters of oxygen. So the pH here is 7.7, which is alkalosis, and the PCO2 is 25. So now the primary disorder looks like respiratory alkalosis, and the bicarb is 17. That means that there is an acidosis here. Now next what you have to see is whether the acidosis, that is bicarb, is less to compensate or not. So we have to do that compensation formula next. The PO2 is 60. That is, it is mild hypoxemia. The lactates are high, and the bicarbonate is 30. So there is an alkalosis here also. but when they have calculated the anion gap, it has come as 17, which is not given here. Okay, so again, if you do the validity formula, the hydrogen ion is 20. Okay, so it matches the pH of 7.7. Okay, so it is a valid ABG. So next, you calculate the AA gradient. The AA gradient has come as 401. Sorry, the PaO2, the alveolar O2 has come as 401. The PO2 is 60. The AA gradient is very high. So definitely there is a lung pathology, and probably because the patient was a rheumatoid arthritis, you can think this patient may be having an interstitial lung disease, and which is suggested by home oxygen in the history, or there may be aspiration. So there is definitely a lung pathology. The PCO2 is 25, so there is a respiratory alkalosis. So now looking at the acid-base disorder, she has metabolic alkalosis, which is shown by because the bicarb is 30. So however, her PCO2 is also low, so she is hyperventilating for some reason. And here probably because of her salicylate intoxication, she is hyperventilating and the PCO2 is low. So in addition, there is a small rise in anion gap. And there is a third acid-base disorder, and that is because of the salicylic acid. So in a salicylic acid poisoning, you will get a combined high anion gap metabolic acidosis with respiratory alkalosis. So this you have to keep in mind. Okay, so that is what it says. The ABG, the alkalosis is because of both is basically because of the respiratory alkalosis, and hypoxemia is because of the ILD in rheumatic because the patient is of a rheumatoid arthritis. Okay, so coming to the next case, it is a 72-year-old male patient who is a known case of COPD, who has presented with fever, cough, and expectoration of 5 days with breathlessness of 1 day. Known diabetes mellitus type 2 and old COX. Also, patient complains of chronic constipation and laxative abuse. So when it comes to this history, you should think that this patient is losing bicarbonate from the bowel. So your thinking goes towards normal anion gap also. So these are the given values. The patient is on FiO2 of 0.9 with an pH of 7.08. The PaO2 is 112. The PCO2 is high, 53.3. The bicarb is low. There is acidosis. Okay, so here again there is both respiratory and metabolic acidosis. Now you have to see, calculate the degree of change. And sodium is 124, chloride is 102, lactates are very high, the albumin is low. Then they have given an urinary sodium, potassium, and chloride, and the pH. So we will try to solve this ABG. So actually it was hyperoxemia. The oxygen was 112, then it is hyperoxemia. The expected PO2, 90% FiO2, 5 times that is 450, but definitely it is less. So there is hypoxia. Then the AA gradient has come to 462. Okay, definitely the AA gradient is high, and the PF ratio is also suggesting there is a moderate hypoxemia. So patient is hypercarbic. So if the patient is on ventilator, what you say is you have to set the ventilator setting properly so that the hypercarbia is resolved. Next, coming to the acid-base status. So the primary disorder is metabolic acidosis because the change in bicarb is more than change in PCO2. The primary disorder is metabolic acidosis. So you have to calculate the compensation. Okay, the given bicarb is 16. 16 times 1.5 plus 8 will be 32. So you should have expected a PCO2 of 32. But the observed PCO2 is 53.3. That means that there is an associated respiratory acidosis. So to know whether to know acute or chronic respiratory acidosis, you should see the change in pH, which I had spoken to you in the last class. Okay, in an in an acute respiratory acidosis, or alkalosis, the change in pH is 0.08 for every 10 change in PCO2, and in chronic respiratory acidosis, chronic respiratory problem, the change in pH is 0.03, either towards acidosis or alkalosis. Okay. Then here the expected the pH is 7.29, and in the example it is 7.08. So the expected pH was 7.29. Because it is 7.08, then you should think there is another additional cause for acidosis. So probably that is a metabolic acidosis here. Then you calculate the normal anion gap. It is coming as 6. Okay, because it is normal anion gap. The next step was to calculate the urinary anion gap, and it has come as minus. So if it is a negative urinary anion gap, so the cause is extrarenal problem, and probably that is because of saline resuscitation. Okay, so to conclude, this patient has got normal anion gap with the acute respiratory acidosis. The oxygenation is poor, and the AA gradient is high, showing that there is an acute infection in this patient. Probably it is an acute exacerbation of COPD. The NAGMA may be due to chronic laxative abuse or hyperchloremic acidosis. So this patient has got both NAGMA and respiratory acidosis. Okay. Next, I think I'll take one example of this, and we will finish up, because it is too much will be too bad for you. So this is an 88-year-old man with previous admission. 15 days back, he was admitted he was operated for fracture of the hip. He got admitted with a sudden onset of unresponsiveness, breathlessness. So there should be some diagnosis which is going to come to you, because this man is post-op hip surgery. Since his GCS was low, he was intubated and put on ventilator. The ABG was taken on day 3 of ventilator, and his lactates kept on increasing, and he expired. So we'll see what is the how we solve this ABG. So the FiO2 is, the patient is on 0.77 FiO2. The pH is 7.05. See, the patient is hypoxemic. There is mild respiratory acidosis, but there is severe metabolic acidosis too. Okay, the change in bicarb is more than the change in PCO2, so the primary disorder here is metabolic. Okay, then the sodium is 132, chloride is 103, lactates are very high, creatinine also is raised, so there is acute kidney injury, and then the albumin is 3. So we told that the patient is hypoxemic because the PaO2 is very low. The expected PO2, because it is the FiO2 70%, 17 to 0.5 will be 350. Okay, it's not 375, it is 350. Okay, then the AA gradient has come as 402. Then that means that there is definitely a respiratory pathology, lung pathology, and the PF ratio is also shows that there is severe hypoxemia. There is, because the patient is the PCO2 is 45, patient is hypercapnic, and because the patient is on ventilator for almost 3 days, the patient needs a ventilatory setting to set the PCO2 back to normal. Now the last step is the acid-base status. Since the pH and bicarb are low, it is a primary metabolic acidosis. So if you do the Winter's formula, the expected PCO2 should have been 27.5, but the PCO2 which has come is how much? 46. So there is an associated respiratory acidosis also. The anion gap is 16. The sodium, the albumin connected anion gap is 18.5. Okay. Then the delta anion gap is 6.5, and the delta bicarb is 11. So the delta ratio is 0.6, pointing towards normal and respiratory NAGMA and HAGMA. So here what we can interpret is it is normal anion gap metabolic acidosis, high anion metabolic acidosis associated with respiratory acidosis too. So this is what the conclusion of this thing is. So there are few more examples. We'll skip that. I think okay. We will do one final ABG before we wind up. So this is a 27-year-old man who was perfectly healthy 24 hours ago when he developed severe watery diarrhea. He had no intake of food and water. He noted that he had a very little urine output over the last few hours. So his BP, he was hypotensive and tachycardic, and his JP was low. So why for a particular reason, I wanted you to show this ABG. Okay. So the pH is 7.39, which is almost normal. And the bicarb is 24, which is also almost normal. And PCO2 is 39. Okay. But you can't just leave it at this level. Patient is sick, but the ABG looks normal. So never look at the ABG. You should, when you get an ABG, always ask what is the history, because all the values are normal. The pH is almost normal, the bicarb is almost normal, the PCO2 is almost normal, but the patient is sick. How can it be? So you do an electrolytes and you find that there is an anion gap of 24. The patient had a diarrhea volume of almost more than 5 liters. Okay. And the hematocrit was 0.6, which is very high. And the albumin was 8, which is also very high. Okay. So this albumin of 8 is contributing to that metabolic acidosis, because this patient has lot of fluid and there is hemo concentration, and that hemo concentration has caused the albumin to raise. So does this patient have significant metabolic acidosis? The answer is no. But why is the anion gap high? So if one use the definition of metabolic acidemia that relies solely on terms like pH and bicarb, the answer is no. But what is the basis of high anion gap here? Because the high anion gap is mainly due to very high albumin because of the contracted extracellular volume rather than the addition of new acids. This is confirmed by the finding that there was only minor elevation in the concentration of either lactate or ketone bodies or the D-lactate, which was less than 1 millimole. So the lesson learned in such ABG is you should always correlate the clinical and laboratory information. Don't treat the ABG, please treat the patient. So that is the reason I wanted to show you this last ABG. Okay, this you will get. So if you just see the ABG and it is normal, but have you asked for an urinary for an serum electrolytes? Have you calculated an anion gap? Even if the pH comes normal and electrolytes are given, you should always calculate the anion gap. Okay. And if there is a normal anion gap, you should always calculate, you should get the urinary electrolytes and urinary pH. And you should always know what is the albumin level. To summarize, so a proper history is important, a complete clinical examination is important, and a list of differential diagnosis should be made, because that's what I was showing you when I showing you the vignettes. I'm showing just by reading the vignette, because in your exams you have to be very smart. You have to go through the vignette properly so that you know what ABG you can expect. So then pick up the ABG to interpret. Once you know the clinical information, only then you take the ABG to interpret, and mainly you treat the patient or the ABG, because it's the patient who is going to give you the bill, not the ABG, isn't it? Thank you, Raghu.
Sir, excellent conference you offer, sir. It was nice, actually. I really enjoyed the class. There are a couple of questions, sir. Just we'll take one by one.
Yeah.
What is towards approach?
That is a strong and difference, isn't it? Yeah. It is a strong and difference method. So what we do here is usually I'll just try to explain. So some Europeans practice this approach. Okay. So what we do is we are given a value of sodium and chloride. Okay. So what is a strong ion difference? There is a lot of depth to this, which Even I am not used to it because I don't do it regularly. But what little I have understood is you have to see the strong ion difference. The strong ion are the sodium and the chloride. So if at all, and what is a normal strong ion difference? It is 38 to 42. This is the normal strong ions. If at all you get a chloride value of 138, okay, sorry, sodium of 138 and a chloride of 90. So what is the formula for strong ion difference is sodium minus chloride. So 138 minus 90. Okay. So here it is 48, isn't it? So in this patient, definitely there is a metabolic alkalosis. Without doing any of those calculation, you can say if the strong anion difference is more than 42, that means that there is an associated metabolic alcohol. You do an anion gap, okay, and then you do a strong anion difference. If it is more than 42, that means there is an alkalosis. If it is less than 38, it means there is an acidosis. So I'll try to tell you, give you one more example. Okay, as I said, the normal strong ion difference is 38 to 42. If you have been given a sodium value of 124 and a chloride of 100. Okay, so 124 minus 100 is only 24. So less than 38. That means that there is metabolic acidosis. So now you have to try to fill so because 38 is a normal and you have accounted for only 24, there is another 14 milliequivalents, which is an unknown acid which is contributing to the acidosis. It can be albumin, it can be a phosphate, or it can be a ketone body. So the examples will be given like that. Okay, so you have to subtract sodium minus chloride, which you will get a value. But the normal strong anion difference is 38 to 42, which you can take an average as 40. Okay, so in this case we got the strong anion difference of 24. That means that there is another 16 acid, weak acid, which is trying to be there. So we with that we have to try to see with a clinical scenario whether it is a diabetic ketoacidosis. Then probably that rest of the 16 can be contributed by the ketone bodies. Okay, so but it is a total different session by itself. But what you have to know is it is a robust approach compared to our Boston traditional approach. Okay.
So we can say in one word, okay, widening of SID and narrowing of SID, which causes
Exactly.
alkalosis and acidosis
Exactly.
respectively.
Correct.
So which one to select? Dr. Shashank want to ask which one to select: plasma bicarbonate, standard bicarbonate, or base excess?
Acha. So usually we take serum bicarbonate.
Serum
Base excess is another method of calculation. The ABG will give you a base excess. Okay. So I told no. So what base excess means? What is base excess? So it is the amount of strong. It is the amount of acid or a base needed to get the pH back to 7.4. Okay, it is an in vitro method. Okay, but again, what are the other criteria? There should be a room temperature or a 37 degrees. Then the carbon dioxide here, they don't take into consideration the respiratory part. So it is presumed that the PCO2 is 40 and the HB is 5 gram %. So this is how the machine calculates. It is an in vitro calculation. So basically it is the amount of acid or base needed to get back the pH to 7.4. If the pH is 7.25, okay, so they would have given some base excess of -8. That means that there is about 8 milliequivalents of acid needed to get back, alkali base needed to get back this pH to 7.4. So the normal base excess is -2 to +2. If it is less than -2, that means that there is a metabolic acidosis. If it is less than -2, it is metabolic acidosis. And if it is more than +2, it is metabolic alkalosis. This is how you have to look at the base excess.
I think that is clear from Dr. Shashank point of view. Dr. Rubina want to ask how anticoagulants affect ABG. Anticoagulants affect ABG.
Achha, you mean to say the heparin?
Heparin, yes, sir.
Yeah. So heparin will sometimes overestimate your ABG. You may not get an proper pH. Okay. So definitely you have to the heparin will definitely come in way of the the blood which you may get may be acidotic, though the patient doesn't have that.
Okay.
Anything more you want to add, Raghu?
Anticoagulants, sir. Nowadays, if you want to do immediate ABG, bedside is there. I don't think heparin is still not required. Immediately you can go. Are you using heparin, sir, now? Heparin based.
Pardon?
Are you using heparin?
We actually used to use pre-heparinized syringes, which come from Abbott. But there again, we started getting very erroneous reading. We have come back to heparin. We use heparin, though our lab is very near. We just rinse the syringe with the heparin.
We won't use, just immediate requirement is immediately we do that.
Achha, if the machine is ready, you don't need.
Yes.
Okay. Yeah. Okay.
How delay in processing affect ABG? Can we consider venous ABG? Dr. Jeevan want to ask.
Yeah. See, actually, as far as my understanding goes, we do arterial blood gas only when we want to know the oxygenation. But for other purposes, if you want to know the renal or a diabetic ketoacidosis and all, VBG is more than enough, because we are more interested to know the bicarb value. There may be a plus or minus 1 or 2 bicarb within VBG, but I think a VBG is more than enough to ABG and arterial blood gas is more important to know the hypoxemia. But for an acid base, if you want to know about the acid base disorder, venous VBG is more than enough.
Correct, sir. Even I agree. Venous ABG is more important than arterial ABG for the acid base status. So next question is how Rubina want to ask how 6 liters of oxygen in example becomes 44%. In one example,
yeah. So for if the this is room air, isn't it? Okay. For every 1 minute, 21 for every, there is a calculation I'll tell you. For if the FiO2 is 24%, the PO2, I think I'll let you know. There is a formula for every 3% of the thing is like that. I got it. Okay. So this is room air, isn't it? If you are using 1 liter oxygen, okay. If you are using 1 liter, you have to add this 21%. For every liter of oxygen, you have to add 3 to the FiO2. Okay. If 1 liter of oxygen is added, if you add 3, it will be 24%. If 2 liters is added, 2 into 3 is 6. 21 plus 6 is 27%. If the 3 liters of oxygen is used, 3 into 3 is 9. 21 plus 9 is 30%. So this is how we calculate the FiO2. Depending on the liters of oxygen. So if it is 6 liters, 6 into 3 is 21. Okay. And room air is 21. That came to 42. I think that was the FiO2 in that example, I think.
6 liters. 44% you have mentioned, I think. They have,
So it is on 42%.
yes. Okay, good, sir. Which one you prefer, delta gap or delta ratio?
Yeah, it totally depends on the clinical scenario, Raghu. So if I start getting negative values, I'll go for a delta gap.
Okay. So next question, again, Dr. Shashank, is it necessary to calculate validity when you told machine itself giving good values? There is no validity, no need.
This is purely for your exam purpose. That you have to know that there is something called as a simple Hasselbalch equation. For that purpose, I have covered that part.
Okay, sir. Next question is how to calculate acute and chronic respiratory problem in one example.
Okay, so I'll give an example. Okay, if at all the pH, if at all the pH is 7.32, okay, and the PCO2 given is 50, okay.
Yes.
Okay, so here I told for every 10 millimeters of mercury change in PCO2 in acute, the pH change will be 0.08, and in chronic it will be 0.03. Okay, so if you take 7.40, and if the PCO2 is given 50, so because the pH has changed to 7.32, this is totally an acute respiratory acidosis. Are you getting it?
Yes, yes.
If it was a chronic respiratory acidosis, the pH should have been 7.37 with a PCO2 of 50. So if the best clue is if they give you an PCO2 of 80, okay, and the pH of 7.32, you can easily say that this is only a chronic respiratory acidosis, because for an PCO2 of 80, that is almost 40 is normal. There is another 40 that is added to make it 80. Okay, 4 times 0.08 should have been the change. That is 0.32. 4 into 0.08 is 0.32. 7.40 minus 0.32 will be 7.08. If the whole thing was acute, then the pH should have been 7.08. But the pH is 7.32. That means that this is a chronic respiratory acidosis. If everything was an acute, then the expected pH should have been 7.08. When there is no major change in pH to a huge change in PCO2, then it is a chronic. Hope I am clear.
Yes. And maybe their question, how can you consider it is acute and chronic? Maybe
yeah, one is history. One is history. Okay, always take history into consideration, and the change in pH. Because I told for every 10 millimeters of mercury change in PCO2, okay, there will be 0.08 change in pH in acute and 0.03 change in chronic. Okay, sometimes there will be they are asking how much is the acute and chronic component. Okay, I got it. Yeah, I got it. So for example, if I tell that the given pH is 7.28, okay, and if at all the PCO2 given is 80, okay, now what you do is you divide this 80 into 4 parts. So the normal by PCO2 is 40, and the PCO2 is raised by 40, isn't it? So what you do is you divide this 10 into 40 into 4 parts. Okay, so the acute component, first 10, 7.42, the pH would have become 7.32. For the next 10, the pH should go from 7.32 to 7.38. to 4, but the pH given here is 7.4 to 8, isn't it? That means that 1.5 component of this is acute, and the remaining 2.5 is chronic. Okay. So a patient who comes with acute exacerbation of an COPD, if the given PCO2 is 80 and the pH is 7.28, 1.5 component, that is around 15. Around because there is, see, 80 PCO2 means your normal is 40. If there has been 40 plus 40. Okay. In this 40, you should see how much is acute part and how much is chronic part. So the chronic part will be the normal pH. The acute part is a deranged pH. Am I confusing, Raghu?
No, sir. Clear.
Yeah. So this is how you should divide it into the acute. If they have got any problem issues, let them. You give me my phone number.
Yes, sure.
And
sir.
they can communicate. They can communicate with me directly.
Yes, sir.
I can explain to them. Because our understanding also has improved over the years. I think these are the same questions I asked you 8 years back.
I think there are no further questions. Anybody, anyone would want to ask question? Raise your hands, and you can ask question directly. Good discussion, sir. It was excellent discussion actually.
Okay.
Especially last case was very good. Only albumin causing the acidosis.
Yeah. So that's what now. Whenever the pH is abnormal, so there are two scenarios. Here you saw everything. The pH was normal, the PCO2 was normal, the bicarb was normal, but the anion gap was high. But there are so many times the pH is abnormal. It will be 7.25 or something. The bicarbonate and they are normal. That also means that there is a mixed disorder. Or you can take it vice versa. The PCO2 and bicarb, they are abnormal, but the pH is normal. That also goes in favor of a mixed disorder.
Yeah, I think we took almost 1.5 hours, sir.
Acha.
Hour 27 minutes exactly. It was excellent discussion. Hope all enjoyed this class, and it will be recorded. Who has not attended, I think it will be put in the website or in the YouTube. Please go through this. If any more questions is, you can ask directly to Guru Prasad sir also. And thank you so much for your valuable time, sir. It was excellent discussion, and even I really enjoyed the class. Yesterday I thought I missed it, but today somehow you gave time.
No, if they want. I wanted to finish it off. I didn't want to keep it because next week I'm little busy, so I wanted to finish it off. What we can do is we can make a interaction between all the students.
Yes.
Let them get few ABGs, and we can sit and solve the ABGs.
Yes. I'll tell them
will also help
come with the few ABCs and difficult ABCs.
Let them share those ABGs first with me. I'll make a small slide, and we will discuss why these were the disorders. History with ABG.
I think you can do it, sir. You can go and come with your holidays. I think we can discuss these. I'll tell them to take a few difficult ABCs which they cannot able to solve. Put forward to you, and we'll solve those ABCs.
Okay.
Thank you so much, sir. Thank you so much.
Thank you, Raghu. Thank you. Thanks for giving me this platform.
Thank you all the students also. Because suddenly they are announcing one date and fixing the class. Still they are coming. Thank you so much, sir. Thank you so much, especially to you, sir. Valuable 2 days, 2 classes.
Okay. Bye.
Bye.